Hello, everyone. Welcome to Endoscopy Talks. I'm David Tweed, and on behalf of Colorado State University's new Translational Medicine Institute and Karl Storr's Veterinary Endoscopy, welcome. I would like to introduce our speaker for today. It's my great pleasure to introduce Dr. Todd Tams. Anyone in the endoscopy world likely knows Todd Tams. He is currently the Chief Medical Officer for VCA. He received his DVM from The Ohio State University, an internship at West LA Animal Hospital, and a residency at Colorado State University. Then, after working at Tufts University and Angel Memorial Hospital in Boston, he returned to LA, where he's been with VCA since the company was founded in 1986. He was medical director for VCA West LA Animal Hospital until 1996. He has published 2 textbooks, Small Animal Endoscopy and a Handbook of Small Animal Gastroenterology. Dr. Todd Tams will talk to us about incorporating endoscopy into your practice, including scope selection, indications, and some case examples. And so now I'll hand this over to Dr. Todd.
Thank you so much for your very kind introduction. It's a pleasure to be here. I appreciate the invitation. I did my residency at CSU, as Dr. Tweet mentioned, and we've worked together over the years. And it's always a pleasure to be affiliated with anything going on with CSU. So welcome, everyone. I'm going to share screen so we can get our slides up. And so we're going to talk about clinical utility of GI endoscopy in practice. And this is a subject that's near and dear to my heart because, all of us who are in practice, we see animals that have GI disorders very commonly. We see animals presenting because of chronic vomiting, chronic diarrhea, could be acute vomiting related to a foreign body, could be acute cases, chronic cases, a lot of different areas, and we'll go through and talk about indications. So this is something that I'm excited about, and hopefully you are either already doing endoscopy and want to progress further, or you're interested in buying an endoscope and you want to learn a little bit about, could this really fit in your practice? So I'm going to start with a case. Let's start off with a case here. This is Suki. Suki is a 14-month-old spayed female golden doodle who was presented because of intermittent vomiting for 8 months. So this is a referral case. So Suki started vomiting around 6 months of age. It's intermittent. Sometimes she vomits food shortly after eating. Sometimes she vomits only bile at any time, could be minutes to hours after eating. And sometimes, though, she vomits food 10 to 12 hours after ingestion. So when you see that and you think, wait a minute, 10 to 12 hours after ingestion, the stomach should be empty by then, because, we'd say that a lot of times the stomach will empty after a meal by 2 to 4 hours after. There's a lot of variables there. It depends on if a dog is eating a high-fat meal, the stomach will empty more slowly. If it's a lower fat, it'll empty more quickly. But for sure, by 7 to 10 hours at the most, the stomach should be empty. So when you see a dog vomiting more than 10 hours after eating, we have to ask, why would that be? And that's an important clue, diagnostic clue. She also had frequent licking of her lips. Maybe that could be indicative of nausea, discomfort, etc. So she had an excellent workup by her primary care veterinarian, and they did a CBC, biochemical profile urinalysis. The blood and urine were all normal. A series of fecal exams, centrifugal flotation, and Giardia antigen testing, looking for parasites, negative across the board. Abdominal radiographs, 3 views, unremarkable. A traveling radiologist came in and did an abdominal ultrasound exam. That was normal. Here's a dog that's young and he had a soft abdomen, easily palpable, and you really wouldn't expect to find anything there. But anyway, the exam was done. The owner obviously was very dedicated. She had a series of food trials, all well done. She was on a hydrolyzed diet. She was on a novel protein diet for a while. And then there were some empirical medications giving, for example, famotidine, metronidazole, etc. But after 8 months, this is still going on. So you have to ask, well, what's going on? Why is this taking so long? Why hasn't anything worked? And so think about, if this was your case, if Suki was your patient, what would you want to do next? So the ruleouts, at that point, we thought she may be nauseated. It's difficult to discern whether that's really occurring in a patient or not in our animal patients, but we thought that might be there. Licking of the lips and, vomiting, she could be nauseated. She could have gastroesophageal reflux disease, which I believe is underdiagnosed in veterinary medicine. It's a very common disorder in human medicine. It's underappreciated in veterinary medicine, especially dogs, not cats. She could have gastric hypomotility from either idiopathic or other known causes. She could have chronic gastritis, Helicobacter gastritis, IBD, or she could still have food sensitivity and they just didn't land yet on a diet that was going to work for her. But thinking about what could we do that would more definitively help us discern what's going on. So it comes to endoscopy. And the beautiful thing about endoscopy is it's a minimally invasive tool. It's very gentle. And you think, well, what would be the risk of doing a GI endoscopy procedure? And the risk is simply this. It's whatever the patient's anesthetic risk is. Of course, we do these procedures under general anesthesia. And so it's whatever the anesthetic risk is, the endoscopy itself is very, very safe. So on the screen here, I have a LES area for a normal dog. So we're at the distal esophagus and you see that there's no opening there. Sometimes you'll see a mild opening, but that's a normal area. And in Suki's situation, you get down to the lower esophagus and it's a wide open door, the lower esophageal sphincter area. And how long did it take us to advance the endoscope along the esophagus to reach that point? 49 seconds. So here she's had issues for 8 months. And it takes us 49 seconds to go down and see she has tremendous laxity. Now, sometimes there will be laxity there related to anesthesia, but when you match up her clinical signs and a gaping area like this, I'd say, that tells you it's abnormal. She did not have the obvious erosive injury in her esophagus, but she did have a wide open LES area. Then you get into the stomach and you see a lot of bilious fluid there. And on the right, you see that there's some coffee grounds there, and the mucosa is redder than you would normally expect it to be. So these are visual clues. When we're doing endoscopy, of course, in a patient like this, we are going to be obtaining biopsies. But we also want to make note of anything that looks abnormal, or note if it's normal or abnormal. So what's abnormal here? I shouldn't expect to see all this bilious fluid there. I shouldn't expect to see the stomach looking red like that. A normal stomach looks like this. So here you see a nice view of the rugal folds there. And the schematic on the right shows where the endoscope tip is located and where the light is, illuminating that area of the stomach. One tip for those of you that are just learning endoscopy, as you go along the stomach and you want to get to the distal stomach and get down to the pyloric area, make sure you're following the railroad tracks. Follow the rugal folds. So we always say follow the tracks, the train tracks, and go parallel with them. If you're going perpendicular to them, you're offline and you need to rotate the scope so you can run parallel to the rugal folds. But that's normal. You don't see bilious fluid there. And so Suki has a lot of fluid accumulated there, and she has a reddened stomach. So we're going to obtain biopsies. We did that, multiple biopsies from the stomach and the intestines. And one question we're commonly asked is, well, how many biopsies do you obtain? And the answer is, in a case like Suki, I would take 8 to 10 biopsies from different areas of the stomach. I would take 8 to 10 biopsies from the small intestine. And absolutely, we would get into the intestine, take biopsies there, even though Suki has not had diarrhea, because animals with inflammatory bowel disease sometimes have only vomiting and not diarrhea. So complete exam for upper GI is biopsies from the stomach and the small intestine. So our biopsies are normal. So we have a working diagnosis. There's no incontrovertible evidence this is exactly what's going on, but piecing everything together, we think that probably she has a combination of gastroesophageal reflux disease and idiopathic gastric hypomotility. What are causes of gastric hypomotility? It could be hypokalemia, hypercalcemia, hypocalcemia, parvoviral enteritis. She didn't have that. Could be chronic gastritis. She had normal biopsies, inflammatory bowel disease, again, normal biopsies. So we ruled out a lot of conditions, and we're left with, okay, probably it's gastric hypomotility. So what are the clues? What tells us that she probably has gastric hypomotility? We go back to the history of the fact that she sometimes vomits undigested food many hours after eating. Why would she do that? Either some type of obstructive disorder or hypomotility in the stomach. Well, as far as obstructive disorders, we examined her antral pyloric region, easily traversed the pylorus to the small intestine. We didn't see any evidence of any obstruction. So we're thinking she's got hypomotility and GERD. So now with the information that we have, we're going to say, okay, let's put her on a prokinetic drug. So a drug like metoclopramide will enhance gastric prokinesis. We'll get some effect in reducing, in increasing tone at the lower esophageal sphincter, and relaxation at the pylorus so that the stomach can evacuate more easily. Omeprazole would be our acid-reducing drug of choice. We'd start that at twice daily dosing. And then for dietary management, of course, for any time we see a GI disease, we're going to ask, well, what's the best dietary management? I would select a restricted fat food. The higher the fat, the slower the stomach will empty. So let's go divided meals, restricted fat. Some dogs with mild gastric hypomotility might respond to this dietary management alone. So this case was seen 10 years ago, and I bring out a case that we had a number of years ago because I want to tell you that we had a lot of years of follow-up with Suki. The question is, well, how long would we need to use prokinetic drugs? Back when we made the diagnosis in 2010, the answer is, I don't know. We're going to have to go with trial and error and see. So we started metoclopramide at TID, going 30 to 45 minutes before meals. And then after a few months, she had a great response to therapy, really, really great response to therapy. She felt better. The vomiting came under control. And the owner said, wow, we've got our dog back. And what did they mean by that? Well, their dog started to feel a lot better, and they had forgotten how active Suki used to be. So I believe that her GI issues were causing her to be more subdued. So as it turns out, she required metoclopramide twice daily long-term. After 2 months, we got her down to BID. After another couple of months, we tried once a day, but every time we lowered her to once daily dosing, some of her signs came back. So we kept her on BID long-term. So we did that based on trial and error. We kept the omeprazole going for about 2 months and then discontinued it. So her long-term therapy was dietary management and prokinetic drugs. But it's a great example. I'm going to show you a video here just showing a normal esophageal exam. And it doesn't take long, so you slide the endoscope in and immediately you get your finger on the air insufflation button so you can start insufflating air. I'm rotating the scope around a little bit. We're going to cross over the base of the heart. There it is. You can see the heart beating there. You can also see tracheal indentation right directly in front of us. I'm going to go up over the trachea there, and the esophagus looks normal, and then we get down to the lower esophageal sphincter there. So it's a matter of seconds. So again, insufflate so that you can see. Just keep your scope tip out in the open. I'm going to slide from the esophagus down into the stomach now through the lower esophageal sphincter. And there you see the rule folds. And there's a leather patch there at the end. And this dog had an issue, was vomiting because it had a foreign body. And that leather patch there was removed endoscopically. But you can see it's not difficult to examine the esophagus. And it's something that we don't do enough in clinical practice. So that's one thing I want to leave you with today is it's important, and you can easily do that when you have an endoscope. Do a great exam of the esophagus, the lower esophageal sphincter area, and the entire stomach. So a point here is endoscopy is minimally invasive, it's gentle, it's underutilized in practice. It provides great patient care because, as you know, our patients can't talk. We have to figure things out, based on clinical science, based on what we find on laboratory tests. But endoscopy is a great extension of our abilities to physically examine an animal. And we want to make sure we try to scope earlier rather than later. So anytime we have veterinarians with us at endoscopy courses, we're very encouraging about you can definitely make endoscopy pay in your practice. It's a great tool. You have the cases. You just have to make sure that you have the training so you know how to use the equipment and know what you're looking at when you get inside. B, it's just a matter of explaining things to the client so that you can make sure that you can do a lot of these procedures. You're going to help more patients if you get endoscopy going more in your practice. And some of you may think, well, okay, this really isn't going to be for me, but hopefully there are some points here that will help you decide when you would refer to a specialist so that that patient does get scoped by someone who has the skills to do it. So here's a long list of the many indications for performing GI endoscopy. And of course, going top to bottom, you think about esophageal disorders. Megaesophagus is not a general indication for doing endoscopy because generally we're going to diagnose megaesophagus on radiographs and then we're going to look for underlying causes. So we generally do not need to scope an animal just to try to diagnose megaesophagus. If you're getting to the point of doing endoscopy to find megaesophagus, you missed a lot. You have to go back. You have to go back and do it. Go about it a different way. But if there's, for example, an obstruction, foreign body in the esophagus, maybe there's a mass. A rare occasion there might be a mass in somewhere in the esophagus, or there may be a stricture. Then by all means, endoscopy is a great tool for that. Dysphagia, retching, unexplained salivation, nausea, inappetence. Oh, a great example on inappetence would be a cat, a middle-aged older cat that has inflammatory bowel disease or small cell lymphoma or lymphoblastic lymphoma. And some of them may not have much vomiting or diarrhea, but the main sign may be decreased appetite. And you're not able to make the diagnosis based on lab work or ultrasound or radiographs. It comes down to doing biopsies. So for a cat that has unexplained inappetence, endoscopy should be under consideration. And then, of course, vomiting of blood. On the right side, diarrhea, melena, straining to defecate. Gosh, endoscopy is great for retrieving foreign bodies. Occasionally, we use endoscopy to put a feeding tube in the stomach or the intestine. We used to do that a lot more, but now we do a lot more esophagostomy tubes, but certainly endoscopy can be used to help place tubes. And then stricture dilation, esophageal strictures, colonic or rectal strictures, endoscopy-guided balloon dilation can be done. So this is a video I'm going to show you from a dog that had an older dog with chronic intermittent vomiting and diarrhea, and had a decreased albumin and decreased globulin, so the proteins were down. And so we have a protein losing enteropathy patient, and it was time to get in there and get biopsies. Don't wait too long on these cases. Get in there. The earlier, the better. But as we go down here, you can see that there's tremendous abnormality here. There's a lot of irregularity. There's troughing, friability. And so you think if you haven't done this before, you can get spectacular views, especially using the endoscopes that we have today with the great new technology. Sometimes we can discern villi. It's really very exciting. So just to show you, when you insufflate, you can get the intestine to distend, you can see very well, and you can get excellent biopsy samples. So that dog had a severe inflammatory bowel disease. Thankfully, it was not lymphoma, and we were able to help that dog with multimodal therapy. So when it comes down to animals with inflammatory bowel disease, for some veterinarians, it's very frustrating, but that's probably because biopsies aren't being done. Remember, it is important to get biopsies because we're going to look at the degree of disease. Where we want to know, is there any, are there crypt abscesses? Is there villus blunting? Is there fibrosis? So make sure you get the biopsies and read the entire report. And, figure that out as best you can, because that's going to determine what therapy we're going to prescribe. We try to tailor therapy based on biopsies, physical exam findings, and any laboratory findings. So it's a combination of those three. So now I want to just talk a little bit about equipment selection and training. So some of you may not have a scope and you're thinking about, okay, what scope should I buy? Some of you may already have a scope and realize that maybe it's time to upgrade it. And some of you may already have a great scope and you're all set. So when I meet veterinarians at the laboratory courses or at lectures, you know, things are all over the board. Remember, when you go in the exhibit hall at the meetings, or you know, you're talking to salespeople that are selling endoscopes, it's not a good idea just to go for the lowest possible price, because you're going to get what you pay for. So when it comes to endoscopy, it's like anything else. With you do a lot of surgery, you want to have really high quality surgical instruments. For endoscopy, you want to get a good scope that you can use and be happy with. Because sometimes you get a scope that may have limited optics or, you know, maneuverability or whatever, and it's frustrating to operate this equipment, and that will become equipment that is not going to be used. I've seen this happen time and time again out in practice. So take time to figure out what really is going to work for you. So what are the key dimensions? I always say know your scope. So you said, hey, I've got an endoscope. I would say, well, how long is it? Is that important? Absolutely. What's the diameter of it? So the diameter of the insertion tube there. And the third point is, what is the diameter of the channel through which we pass our operating instruments? The larger the channel, the bigger the instruments you can pass through there, and that is very important. Why is the length of the scope important? Well, if you're evaluating a dog that weighs, you know, 45 kilos, or more, even more than 20, 25 kilos sometimes, your endoscope, if you're using a shorter scope, say maybe 100 centimeters, your scope may not be long enough to pass through the pylorus. You may be able to get into the stomach and see the pylorus and get up close to it, but then you're out of operating length and you can't pass into the intestines, and you're going to miss a lot of disease if you can't get into the intestine. So for really big dogs, you need to have a longer scope. Remember, in animals, in dogs, their esophagus is generally longer, relatively speaking, than the esophagus of a person. In people, it's usually around 20 to 22 centimeters long. So we have dogs where the esophagus is somewhat longer. You need a longer scope. So most endoscopes are going to have a 2.0 millimeter channel, or a 2.2, or a 2.8. So again, the advantage of the larger channel is you can pass larger biopsy forceps through there. That means larger tissue sample size. Great. We're going to do a better job on evaluating any areas we're biopsying, and larger foreign body grasper. So for example, if you have a 2.8 channel, you can pass a giant basket through your scope, and you could retrieve ping pong balls and golf balls with that instrument. But that basket will not fit through the instrument channel of a scope if it's 2 or 2.2 millimeter diameter. You have to have a 2.8 channel to fit that instrument through. So yes, the instrument channel diameter is very, very important. So 2.8 is ideal, but you know, sometimes you give away, what do you give away if you have that big channel? Well, the scope diameter may be big, depending on which scope you have. You bought a used scope, maybe you bought a big diameter scope that's got that channel, but maybe the diameter of the scope, the insertion tube, is going to be too big for you to comfortably pass the scope through the pylorus. So now you've got a big problem. If your scope is too big in diameter, and in smaller patients you can't get through the pylorus, you're going to miss things because you're not getting down into the small intestine. Okay, so what is the ideal scope? So for veterinary practice, and again, I'm going to say, let's say for general practice where you can afford to buy one high quality scope. It's not like a specialty hospital where they're going to have 3, 4, 5, 6 different scopes, you know, all different sizes. So one scope that can do it all, you're going to want a narrow diameter scope with a big instrument channel. Narrow diameter, easier to pass through the pylorus. Bigger instrument channel, larger instruments. So there is a scope. This is a newer scope available from stores, and we've been using this scope for probably over the last 5 or 6 years now. And these dimensions are great. So 140 centimeters long. So that's going to be long enough for you to be able to advance your scope through the pylorus and into the upper small bowel of even really large dogs. What length are equine scopes? Around 300 centimeters, so 3 meters long. So for a big dog, 140 is really good. This scope has a 7.9 millimeter diameter. I always say 9 millimeter diameter or less is ideal for small animal practice. I'm talking ideal. You could use a large diameter scope to some degree in your practice, but I want to be very versatile. So I'm going to say what's ideal, and that's, less than 9 millimeter diameter. So it's 7.9 diameter and a 2.8 millimeter instrument channel. And that's absolutely ideal. So this is excellent for small as well as large patients. So we can pass this endoscope through a cat pylorus, and cats as small as 3 pounds, 3-4 pounds, a couple of kilos. And we can pass it through the pylorus of big dogs because the length is there, the 140 centimeters. So this is a very, very versatile scope for small animal practice. The Storz also has a scope that's smaller in diameter. This is 7.9. They have a 5.9 diameter scope for even smaller patients, and that is a scope with 110 centimeters along. For smaller cats and dogs, of course, you don't really need 140 centimeters. A shorter length is okay. So there is a 5.9 millimeter scope that's available, and if you see a lot of cats and small dogs, that might be a scope you'd want to take a look at. Okay, one other thing on scopes is if you have been in the market to buy used human flexible equipment, maybe you're feeling like, gosh, I want to get started, but I can't quite afford the ideal, really great scope. So I'm going to start with this and hopefully get busy and make some revenue on it and then be able to buy an ideal scope later. So if you're shopping for used, you might have already purchased a scope that's, a lot of times in human medicine, the upper GI scopes are about 100 centimeters long, the pediatric ones. Diameter is 7.8 to 9 millimeter, but these scopes generally have a 2.0 millimeter instrument channel. So what do you lose when you have a 100 centimeter scope? Well, it might be too short to reach the upper small bowel in some large dogs. It's great for cats, it's ideal because the diameter is really good, but the channel is small. And so for years, when I was learning endoscopy and early in my career, this was the size scope that we used, and it had a 2.0 channel. Now, with the availability of the 2.8 channel, I love to use that particular scope. So I did use a 2 channel for a long time, but I really, really do like the 2.8 channel feature. Another way you might have gone or might be thinking about going is, well, I want to get that scope with a big channel. And so you're looking around, and so a sales rep might say, well, we've got a used scope. It's 9.7 or 9.8 millimeter diameter, but gosh, you've got that big channel, a 2.8 channel. What's good about this scope? Larger channel, and you can pass larger instruments through there. What's bad? Well, it's over what I say is, the ideal cutoff line, which is you want a scope less than 9 millimeter diameter. At 9.8, there will be some smaller patients that you're just not going to be able to pass through the pylorus on, so you're going to lose. If your main focus is getting gastric foreign bodies out, and you're an ER doctor, then, hey, that bigger scope is great because it's going to be a great gastroscope. You're just not going to, in some of your patients, you're not going to be able to get down into the small bowel to look and see if there's anything going on down there as well. So I hope these tips are useful. We'll see if there's any questions about that. So just to wrap up on this part, the ideal diameter is 6 to 8 millimeter, 9 or less, but ideal 6 to 8 is really great. It's just going to be easier for less experienced endoscopists to pass through the pylorus. You're going to, of course, want 4-way tip deflection. We're doing GI work here, so you need a 4-way tip scope. All GI scopes have 4-way tip deflection. You're going to really shoot for a scope that's 140 centimeters long, because then you're going to know you're going to be able to get through the duodenum, into the duodenum in even big dogs. And then that big channel. And of course, always look at the optics and maneuverability. This is what you pay for. Gosh, it's really exciting to go in and see things that with the older scopes, we never saw. And so try, if you can, to think about how to get one of these better scopes. I'm going to talk a little bit. We'll stop for questions in just a couple minutes here, and after that, I'm going to talk about how to figure out if you can afford a really good scope or not. So I'll get into that shortly. So here's another example. This is Shauna, a 3-year-old Irish Wolfhound who was 80 kilograms. She had a history of chronic intermittent vomiting and diarrhea for 3 months. So on again, off again, she had some hematochezia, see blood there in her feces, and she vomited a little bit of blood. So she was actually, she had a workup of, the baseline blood, urine, GI parasite exams, radiographs, ultrasound, and, TLI, B12, and folate, and a lot of things we do. But the bottom line is it came time to do biopsies. So how are you going to do biopsies on this Irish Wolfhound? Do you want to have them done endoscopically, i.e. minimally invasively? Or do you want to go ahead and open her up and do full thickness GI biopsies? And I think it's great to be able to get full thickness biopsies, but you have to think this through and figure, well, how's it going to go for her? Do we really need it to do it invasively? Do we need to open her up? And how's her recovery going to go and all that? So, boy, endoscopy is great for, the minimally invasive part. You can get in upper and lower. We're going to be able to go up her colon and get into the ileum. We do that routinely. So we do ileoscopy, so we get up or lower. We're very, very thorough. And we had a 140 centimeter scope. So Dr. Sean Yoshimoto, one of our internists at VCA West LA, was doing this procedure, and I was observing with him. And you can see that the scope has been advanced as far as it can possibly go. And luckily at that point, Dr. Yoshimoto was in the small intestine, so we were able to get biopsies, and then we did lower as well. So she had inflammatory bowel disease. She had a moderate lymphoplasmacytic enteritis. She didn't have any crypt abscesses or anything. She also had ileitis, and she had colitis as well. So we managed her with diet, plus she did get on steroids, very conservative dose of steroids. She's a giant breed dog, so we're going to be careful with how much steroid we give. But the beautiful thing was we knew what she had, we knew the degree of disease she had, and we were able to tailor therapy to what she really needed. Okay, I've got a question for you guys before you start hitting me with questions. Here's the question. Approximately what percentage of gastric foreign body cases in dogs and cats can be successfully managed via endoscopic retrieval? So you've got a case with a gastric, so it's gastric foreign bodies. We're talking stomach. So what do you think? Would it be 5% or 10 to 20%? I'm thinking not this group who's on with us tonight. You guys are interested in endoscopy and you're pretty savvy. So the answer is it's actually a little over 85%. So these days we'd say 85 to 90%. So and this was a series we did at my home hospital, VCA West LA. We looked at over 600 dogs and cats who had a gastric foreign body. Some of them are from our general practice component of our hospital, and some were referred to our specialty side of the hospital. So we looked at all these cases, and that's how we figured out, what our success rate is in a large number of cases. So just some examples. Way back in my career, the first foreign body case I ever had was in a golden retriever. You see those 2 rocks up there in the upper left. That was my first experience in retrieving foreign bodies. And we were successful in getting those out using a 2-prong grasper, so that dog did not need surgery. Leashes are fun to take out. Dog had eaten a leash, and the owner was in denial. So, okay, so this is a Labrador Retriever, of course, and you know what I'm saying when I say the owner was in denial that her dog could have, in any way, shape, or form, eaten the leash that has been missing. And this dog came to see me on a Friday morning as a walk-in, and the dog had been vomiting for 10 days. Poor dog. So they came in, and my goal was to get the dog home for dinner. So we did radiographs and saw that there was a leash in the stomach, and we gave IV fluids for a few hours to get the dog rehydrated. Did endoscopy. It took 20 minutes to get the leash out, and the dog went home that night for dinner. So endoscopy was beautiful because, it's nice when you can avoid having to do open abdomen. A needle foreign body in a cat, that's an easy one to do. That would take maybe about a minute or two once you have experience to go down and grasp it. You just grasp the foreign body, pull it up to the tip of the scope, and then pull it out. Of course, we're not pulling anything through the instrument channel. You just pull the foreign body right up to the tip. There's a nice video. This was sent to me by one of our doctors who came to an endoscopy course. So this is at a hospital in Philadelphia. They came out to an endoscopy course, and went back home after the course and then did this video, and I was really excited to see that they put to work what they learned in the course. So they pulled out 2 athletic socks from this dog's stomach. The owner, a single guy who, he admitted he left his socks laying around all the time. He was elated. He was just so excited that he could have this done endoscopically, and that, he didn't cause his dog to have surgery. So he was really, really happy. You talk about, owners and what they really want. Obviously, they want minimally invasive. We would want that for our own pet, and that's all of our clients feel the same way. So that was an awesome case. There's another one. I'm just going to show you using a big basket. There's a round object in the stomach here. So I've got the catheter down there, and we're going to extend the basket. You just kind of work it and try to get underneath and get the arms around it. And I'll show you what this basket looks like after we get this case done. But once you have that caught, you've got the object caught inside the basket, you're not going to drop it on the way out. So you pull the foreign body up to the tip of the scope. Now that's going to be the view. You've right up to the tip of the scope, and we're gonna maneuver the scope a little bit so we can ease it up through the lower esophageal sphincter. Notice there's no yanking or jamming or anything. Now we're back in the esophagus. You can see there was a color change from pink red to cream colored, and out you go. So always be gentle. That's why we love to have you come to courses, because we can demonstrate to you, the really good techniques. This is just an example using the basket. That's a Halloween themed ping pong ball there that was removed. This dog, it was Halloween season. The dog swallowed a ping pong ball, so it came out with the basket. So the small basket on the left is the size basket we had available for years. And gosh, now we have over these last 3 or 4 years, this giant basket, and it's made a big difference. So yeah, it's a great instrument to have, but remember, if you want to use that instrument, you have to have an instrument channel in your scope of 2.8 millimeter diameter to fit the catheter through there. But it's a really, really great tool to have. So those are fun cases. So Dr. Tweed, I'm going to stop for a minute. Julius and Ed are reminding me here that it's time for questions. So do we have any questions in the queue?
Yeah, we got a couple of questions, and I also have a comment. I know out at West LA, you get about 85% of the foreign bodies out. I think at Colorado State University, we're up there at 95% plus. But anyway, one question that we have is, how do you keep appropriate gastric insufflation with the open esophageal sphincter?
A good question. So, and that's a good point, because we're not really talking a lot of technique today, but that's a good question to answer. So when you arrive in the stomach, the first thing is get into the stomach, stop advancing the scope, and insufflate air. So your finger is pretty much living on the air insufflation so that it'll inflate. Sometimes there will be reflux from the stomach, reflux out, back through an open esophageal sphincter, and the air just escapes. So I'll have an assistant gently clamp down on the neck to block egress of air. But generally, like in Suki's case, it really wasn't difficult to keep it insufflated once we put some pressure on the neck. So that's generally what we'll do. Sometimes it takes longer to get the stomach insufflated, but we are able to get there. So just don't give up at constant air insufflation.
Okay, we've got another quick question. I think you answered it pretty much, but if you had a feline-only practice, what scope would you recommend?
That's a great question. So feline-only practice, I would say, if you had, say, the 100 centimeter or 110 centimeter scope, so there's you could go with the shorter scope. What you're going to give up with that, say the 110 centimeter scope that's 5.9 diameter, that's beautiful. And that's also one, by the way, that our Zoom Ed specialist uses on ferrets. So ferrets can get inflammatory bowel disease, so it's a great scope for ferrets. It's just that scope has a 2.0 millimeter channel, but that's okay. In cats, you can still get a lot done with that particular scope. So if I had a feline only practice and I was buying a new scope, I'd go with 110 centimeter length, 5.9 diameter, Or if you had one that, but the one that I talked about, the 140 centimeter long one, that still works fine in cats. It's just that, you have that extra length that you don't really need.
Yeah, okay. Why do you take 8 or more biopsies at each area?
So 8 or 10 biopsies would be from the entire stomach. So we'll take a few from the antral area, a few from the gastric body, a few from the fundus cardia area, and in the intestine take samples along the way because disease can be patchy. And, these samples are small and I don't want to miss something. So what pathologists always ask for is multiples, give us the opportunity to evaluate a lot of tissue. And we also know that when, just by nature of the way we obtain our biopsies, if you take 12 biopsies, you can count on 4 of them being probably really, really good. 4 may be mediocre and 4 may be really kind of trashed, not very good quality. So you want to give your pathologist the opportunity to have enough tissue to evaluate in a variety of areas. So multiples are important.
Okay, we have one more, and that is, when do you decide or what size of foreign body do we not remove through the endoscope if you think it will damage the esophagus?
Okay, good question. So, yeah, and another question is, well, when do you give them a drug like apomorphine to induce vomiting? It's a question we always have at rounds every day with our criticalists and the interns. That we have a foreign body patient in the hospital, and the question is, should we induce vomiting, or are we going to go with endoscopy? Are we going to go high tech and get in there with the scope? So rounded objects, if first of all, on the apomorphine question, if it's anything sharp, we're not going to give that. I want the animal to be alert, be able to swallow normally, have good control before we induce vomiting. So I don't want an animal that's really subdued or depressed. I'm not going to do it in that case. But as far as endoscopy, if you have the right tools, we can get golf balls and ping pong balls out. I think if something's really sharp, you might have to be careful because you might worry about, pulling something sharp up through there. But, you have to then step back and say, well, wait a minute, how did it get in there? The animal swallowed it. It got in there. So could it come out? And I find that there are many things we can get, and sometimes it's going to take a while, but if you're patient and no ramming or jamming or yanking or anything, just gentle, steady pressure using the right instruments. And I only showed you examples of a few instruments. I mean, there are a variety of instruments you can buy that can help. And at some of our endoscopy courses, we actually put foreign bodies in the animals, and then the participants take them out. So if it's really sharp, or if it's going to take a long time, maybe you think, you know what, if we can't get this foreign body out by 45 minutes, gosh, we've got clients coming in, maybe we have to move on. So sometimes it's a matter of how much time you have available, how many doctors you have in your practice. But I mean, you'd be amazed at what you can actually get back out. Good questions.
Okay, I think we probably should move on. If we have a few more questions, and so if we have time at the end, we'll try to hit those.
Sounds great, Dave. Thank you very much. Okay, so now I wanted to talk a little bit about, say, what if you're interested in buying an endoscope, or you have a scope and you're realizing, maybe I really should think about upgrading to a newer model. So just like anything else, as a practice owner, you would do a business plan. And so I would want to maintain a record of the number of cases you see that should ideally be scoped. So you keep a record of, see an animal with vomiting or diarrhea or unexplained decreased appetite, and you're thinking, I've been trying to manage this case for a while. Maybe I ought to quit messing around here and really just get down to business and get some biopsies. I'm always on the side of scoping earlier rather than later. What's the value to the patient of waiting and waiting? They need help. So I try to lean on the side of, talking to the owner about, we have a way to help. We have a way to get in there and really answer a lot of questions. And we can do it minimally invasively. So you have to be passionate with your recommendations and really bought into it, because of course the owners can see if we're really bought into what we're recommending or not. So keep a record of how many per month you would do, and what are the anticipated fees for the exams. So the third bullet point says set fees for increased volume. In other words, don't overprice. If you're trying to learn endoscopy or any other technique, or you want to be able to afford equipment, I want to go for volume. So I want more people to be able to say yes. So set your fees at a reasonable level. If you get really good at this, you can, do whatever you want with your fees later on. But initially, I'm talking about early on, set for, volume. And then you figure out, well, okay, you talk to, sales reps at the companies and, you look at some really good scopes and you're going to say, gosh, should I buy it or lease it? So in talking with sales reps, a lot of times they'll tell me that about 50% of the hospitals will pick up equipment on a lease deal and 50% outright buy it. So you'll have to figure out with your accountant and everything, what's going to be best for you. But if you do at least 3 or 4 cases a month, you should be fine. And I mean, what practice doesn't have 3 or 4 cases per month? Even a 1 or 2 doctor practice is going to see cases that really need to be scoped. I mean, in a bigger practice, you're going to be doing multiples. Smaller practice, you won't be doing that many, but you can still do enough. And then invest in training. So learn how and know your limits as well. I mean, bottom line is we want to provide really high quality care. And if you're a generalist, there still will be cases you're going to need to refer to a specialist. I'm not going to go into all the reasons, but there are times when you're going to want to just refer it. And other times you can manage it yourself. So, we're always driven by do what's best for the patient and treat our clients and patients as we ourselves would like to be treated. That's just been my philosophy. But the bottom line is get in the room, be excited, and really tell clients about, what great things can be done with endoscopy. And think about how many humans are scoped around the world every day. Thousands and thousands of people. So the cases are there. They're providing great medicine in a minimally invasive way. You're getting earlier and more definitive diagnoses, and you can recommend this technology to clients with confidence. But again, do the training, do the reading, read the books, go to courses, and do the training. When you do an internal medicine residency over the course of 3 years, like I did my residency with Dr. Tweet, I got a chance to learn over, a long period of time. When you're in private practice on your own, you have to think about, well, how am I going to get my experience? And that is through courses and reading and, taking, attending sessions like this one, which hopefully is helpful to you. So here's an example of one of our hospitals, BCA Westboro in Boston. Smaller hospital. It's a 5-doctor hospital, but there you see in their surgery room, they've got 2 endoscopes, and it's always good to keep your endoscopes in a hanging position. They shouldn't live in the suitcase. They should always be kept hanging. And several of the doctors took an endoscopy course, and if you have a multiple doctor practice, I always recommend that more than 1 doctor take the courses, because then the 2 or 3 who take the course can work together on cases and continue to learn by helping each other. So I asked the doctors after 7 months, well, how many cases have you done? So you keep a record of what you're actually doing. So they had done 17 upper GI endoscopies. They did 2 colonoscopies. That's a little thin. There should be more of those. They also did rigid. They did 6 laparoscopies. They had an exotic specialist who does reptile work. So they did reptile laparoscopies, cystoscopies. They did a lot of video otoscopy, which is great. And that's something every general practice should have, is a good video otoscope system. Anyway, the revenue from just the endoscopy part over the 7 months was $26,000. And that didn't include the other ancillary fees, which would be IV catheter, whatever you charge for the anesthesia, pre-anesthesia tests, biopsies, et cetera, whatever else is done. So they were doing well. But you know what they told me after that 7 months? Gosh, we thought we had done more. And I love to hear that, because their attitude was, gosh, they were disappointed. These are pretty good numbers for a primary care practice, but they could be even higher. So I thought they did really well. This is my home base, BCA West Los Angeles, a very, big hospital. It's, any of you from around the world, if you come to Los Angeles, we'd love to have you stop by and see us. This hospital, up until 2013, was actually an office building. And we took over the building and renovated it into an animal hospital. So we have 62 doctors. It's both general and specialty practice. It's 24 hours a day, 7 days a week. We have a big internship program. We have trained a lot of residents there. And the projected revenue for this year should be around, we think 35, 36 million US dollars. So big, busy, very, very busy practice. So just to compare, so these are our numbers last year. We did 481 upper GI. Just the endoscopy part is $893. That doesn't include all the ancillary work. 108 colonoscopies. I didn't get the number. There's some combo where, you know, we do upper GI and colonoscopy together. We're doing a lot more of those. And our exotic specialists also are doing some endoscopy. The real charge is what we'll quote to a client for an upper GI procedure is around $1,800 or $1,900. That's everything included. That's a big, busy practice in a city like Los Angeles. If you're starting out in a primary care hospital in a smaller town area, those fees are going to be difficult to justify. You're going to start smaller. In our company, VCA, we have a lot of hospitals in smaller towns. We may start around $400 to $600 is the fee to do an upper GI endoscopy. You have to hit a price point that's going to work. Again, you're thinking, I want to provide great quality care for my patients. I want to do these procedures. I want to get good at it. And bottom line is you do it because you want to help your patients in a really minimally invasive way. So these are just some examples of what it is. A couple other points as we start to wrap up here in just a little bit. Just on handling an endoscope, it's really important when veterinarians come to courses. I find that if they've already been doing endoscopy, they might have picked up some bad habits where, you know, it's just going to be difficult to really use the scope efficiently. So remember that there are two buttons up on top there. You see an orange and a blue. The blue one, it controls air and water. So air insufflation, we have to be able to insufflate air into a patient to get the walls to distend so that we can see. And then we want to be able to flush water so that we can clean the lens and maybe use it a little bit to clear the mucosa a little bit. So that blue button controls both of those actions. And then the orange or red one does control suction. So you just connect up your suction, your standard suction pump, you hook up your tubing to a port on the endoscope housing. And then you have two control knobs, a large one and a small one. The large one controls up, down. The outer smaller one controls left, right action. And then this is just a fiber scope I put in here as an example. So looking through the eyepiece there's a focus ring. But these days we generally are using video endoscopes. You're not looking through the eyepiece, you're just looking up at a monitor. So those are the components. So how do you actually, what's the best way to hold the endoscope? So I like to use a 2-finger or a 3-finger grip. So you see the 4th and 5th fingers are down lower on the housing there. My 2nd and 3rd finger are operating the buttons. And then if you look on the right, you can see how my left thumb is coming around there. And you are actually using your thumb to turn the large control knob. You want to be as efficient as you can. The more you can do with your left hand, the more it frees your right hand to advance and retract the scope. Advance and retract. So that's the 2-finger technique. So think about how you hold the scope, because you want to be as efficient and comfortable as you possibly can. This is a 3-finger grip, so 3 fingers on the housing and using your index or 2nd finger to control the buttons there. And again, using your thumb around the back side. So you're also going to be, this is just showing one of our courses, one of the veterinarians holding the scope. It's a left hand, so you're holding it in your left hand because those control knobs come off on the right side. So you see holding, it's a fiber scope that has a camera on the eyepiece there. So they're observing everything that's going on a monitor. So the right hand is being used to advance and retract the scope. And notice that they're standing in front of the patient. The dog is in left lateral recumbency, and the nose is at the tip of the table. And then over there on the right, just showing how you sometimes bring your right hand up to work the small control knob. For example, if you're trying to maneuver through the pylorus, and you really need precise control on the tip of your scope, precise control. You don't want to be jamming the scope around. It's not a sword fight. You want to be very slow and, take it easy and don't push it too hard, too fast. but you need to keep the tip right on line with the pyloric orifice. So you might need to have both hands up there, and maybe somebody will help you a little bit advancing the scope tip to help you get through. There's lots of different ways to do it. And then as far as somebody was asking about instruments, as far as biopsy instruments, if you look at the top row there, the sixth one from the left, you see it has serrated edges. It's an alligator jaw biopsy forceps. That's my favorite one. I think we get better quality biopsy forceps with that. You see a couple of instruments there have a bayonet point. The theory there is that if you open up the cups, that you can use the bayonet point to lock into the mucosa a little bit. But honestly, I like to use the alligator forceps. I think that gives us the best biopsies. These days we use disposable biopsy forceps a lot. We use them on maybe one to three cases, and that's it. In human medicine, one biopsy, of course, instrument per patient, and that's it. Then it's discarded. Be careful to not get in the rut of using dulled biopsy cups. You won't get very good biopsies that way. Okay, and then wrapping up, starting a procedure, the last things, general anesthesia. Always have the patient in left lateral recumbency. That means the pylorus is going to be up away from the tabletop. The pylorus is on the right side. So left lateral recumbency. I like to put the oral speculum on the deep pendant canine teeth, so just get it out of your way. Tie the endotracheal tube ventrally. Position the patient's nose at the front end of the table and stand in front. And by the way, this is not a good procedure to be doing sitting down. You really need to interact. You need to be able to move and kind of bend and back and forth. So we definitely recommend, unless you have back pain or something, that you try to be standing up when you do these procedures, because you really have to be interactive with the patient. Okay, now if you look at this image in the stomach, you look at the rugal folds, and you see that if we go straight with the scope, we're going to go perpendicular to the rugal folds, and we're going to get stuck in the wall. This is the #1 most common error beginning endoscopists make. And I wanted to just show you this picture because some of you might be dealing with this issue. Where we really want to go is that open area off to the upper right. Okay, if we go straight ahead, we're stuck in, we're not going to go anywhere. So advance parallel to the rugal folds, not that way. Yeah, follow the green arrow. That's where we want to go there. In this video, we'll just show you, we're kind of looking perpendicular to those rugal folds, and I'm going to use my right hand to torque. So I'm torquing the insertion tube to turn it. I'm turning the large control knob backwards, and now we're right on line. And there you see the angulus fold up there. And if you go under that bridge, you're going to go right down to the pylorus. If you go over the top of it and turn the big control knob back, you've got the retroversion maneuver, and you can look way up into the fundus area of the stomach there. You get a beautiful view. It's spectacular. How can we get this great view? You've got enough air in there. You distend the stomach, and now you can just rotate and get a really beautiful view there. So keep the air in the stomach, get in there, follow the rugal folds, take a good look around, and once you finish that, then you can move on. And then on this one, it's just going to show you, we got this is one or two more to go, and then we're done. Okay, so now we're advancing the scope down into the antrum, and there you see the pylorus. So this is a time when you do not want to be jabbing the pylorus, because you're not going to go through that way. So you line up right on line, and I could see that I was going to have to turn right. So to turn right, it's a small control knob forward, and just like that, we just went through the pylorus. So be patient, take your time, and line it up. And then you can find the lumen. We're insufflating air, and you have a beautiful view down there looking down into the small bowel. And then you use the control knobs to deflect the tip of the scope so you can stay right on line. And then this one will just show you what it looks like when you're doing an intestinal biopsy. So you can see the cups open, close, open. I'm then going to engage the wall and push in. Give it a good bite. You're not going to perforate anything. So you got to be bold on these. Now you can pull back and snap off a sample, and got a nice biopsy sample out of that one. Okay, so that's just to show you, just to give you an idea of what it looks like when you're doing the biopsies. And then, of course, you do colonoscopy and ileoscopy. The goal is to get the tip of the scope up to the ileocholic orifice. So you can see what it looks like on a radiograph there, the reverse question mark anatomy. And on the right, you see an opening to the lower right. That's the cecocholic orifice. And the mushroom structure is the ileocholic junction. And you can pass the endoscope up into the ileum there. And this is the last one. I know there was probably going to be a question about how do you get into the ileum of a cat. So it's difficult. If you have a bigger scope, you're not going to be able to pass it through. So remember the anatomy of a cat. This is a cat with air contrast. So you see that the ascending colon in a cat is very, very short segment, and the cecum is very small. So on the upper right image, you're looking into the cecum there straight ahead, and you see that very small round opening above it. So we torque the scope around in the ascending colon to get that view. If you can't get your scope in there, we do what I'm showing in the bottom right there, which is you advance the instrument, the biopsy instrument, blindly through the ileocholic orifice, and you can then get up in there and take biopsies. We'll take 3 or 4. But if you have one of those 5.9 millimeter diameter scopes, you'll have a better chance of actually getting in there. And so I want to give you a lot of encouragement to find a course, come to a course. There are great courses at the Translational Medicine Institute at Colorado State University, the Oquendo Center in Las Vegas, sometimes at the University of Tennessee, various centers around the world. We've taught courses in locations around the world. Find a course that you can go to and really get some really good hands-on experience. Learn how to do it right, and then keep practicing. And then we have the reference test that Dr. Tweed mentioned earlier. There's over 1,200 photos in there and chapters on both flexible and rigid endoscopy, how to do it. So if you take time to read there, you'll learn a lot of the techniques as well. So with that, I'm wrapping it up. So Dave, do we have time for any additional questions? Maybe a few, or are we out of time?
You know, Todd, I'm afraid we're out of time at this point.
Okay.
So, hey, thanks so much. There's a lot of good stuff there, and really appreciate that. What we're going to do is this webinar will be available online for viewing at a later time. There are a couple of questions. We'll try to answer those offline. And thanks everyone for joining with us. Next week, we're going to have an international speaker, our first international speaker from the UK. We will have more international speakers as we go along. Dr. Philip Lamette, he's going to talk about beyond the lap spay, expanding your repertoire. And this promises to be some really great information related to lap surgery. So I encourage you to join us for that. That will be next Wednesday, July 22nd at 2 p.m. Eastern Daylight Time. That's New York time. So wishing you all good practice, good health, and we look forward to seeing you next time. So thanks a lot, everybody.